So, welcome to our Ateneum Pontificio Regina Apostolorum, European University of Rome. I'm Father Alberto Carrara, Dean of the Faculty of Philosophy here in the Pontifical Ateneum Regina Apostolorum, and I'm the director of the Neurobioethics Research Group. So today the meeting will be in English, okay? E benvenuti per tutti coloro che parlano in italiano, e ci sarà anche la traduzione dall'inglese all'italiano attraverso la piattaforma Zoom per tutti coloro che si sono iscritti e che stanno entrando. So I prepared this brief, brief no, not brief, but this introduction. And so distinguished colleagues, dear friends, distinguished faculty, students, and guests, good afternoon. And it is a privilege to open the Neurobioethics Open Class Lecture Series today here in Rome. And it is with deep joy and sincere gratitude that I welcome you to this gathering. Yes, a gathering, but also a moment of shared vision and commitment. Today, we are not only engaging in academic exercise, we are bearing witness to a journey, a collaboration, and a shared ethical call. And I'm especially honored to extend my heartfelt thanks to the two extraordinary people and colleagues that I have here with me. Dr. Steven Stahl and Dr. Catherine Borburtur. Thank you to be here. Their brilliance, integrity, and compassion have not only shaped our scholarly efforts, but also given soul and heart to what has become ICONN. I am going to present something about ICONN. And this initiative, born out of shared concern for the most vulnerable, has become a beacon of hope and renewal in global psychiatric ethics, I guess. Stephen, Catherine, thank you for being here and for walking this path together. And so Stephen and Catherine are here. We were in San Diego last week at the Psych Congress. And in few days, Monday and Tuesday, here, we are going to celebrate the first ICONN colloquium. So it's a special moment, a historical moment, I guess. Above all, I thank also God for his providence, which has not only inspired, but continues to bless this work. I believe firmly that ICONN, the International College of Neuroethics and Neuroscience, and all our shared efforts in neuroethics and mental health exist not by accident, but as part of a large design to serve humanity with greater dignity, justice, and love. In striving for a more compassionate psychiatry, a more ethically grounded neuroscience, and a more inclusive vision of health and longevity, we take part in something larger than ourselves. May our time today and in the next days, the work that follows bear fruit in lives healed and hearts uplift. So I share my presentation. In the spirit of interdisciplinary inquiry that marks contemporary bioethics, neuroethics, our discussion will weave together threads from psychiatry, neuroscience, ethics, and global health. We will explore how the care of the brain and mind over the life course calls for an integrated vision, one that honors scientific advances, respects human dignity, and embraces international collaboration. In particular, we will highlight some key domains, the mission and vision of the International College of Neuroethics and Neuroscience, the Vatican's new longevity project, the convergence of psychiatric neuroethics with global mental health and longevity, and also some relevant WHO, the World Health Organization, and United Nations mental health frameworks. Our human lifespan is extending unprecedentedly, we can say. A triumph of science and public health, but living longer also poses profound questions, like how do we guarantee not just longer lives, but healthier minds and more fulfilling years? The first Vatican recent Longevity Summit, March 24th, and the ongoing longevity project directly address this question, insisting that living longer must be accomplished by living better with health, dignity, solidarity, and justice for all, the very important principle of the UNESCO Declaration on Bioethics and Human Rights, 2005. This for all means the equity. At the same time, mental health conditions already account for a growing share of the global burden of disease. Disorders, you understand better during the presentation of Professor and Dr. Stahl and Dr. Bourbourtour. Disorders like schizophrenia, depression, dementia challenge individuals and society. They pose questions at the intersection of neuroscience, ethics, social justice, and law. Questions that give rise to some that my colleague and friend Walter Glennon in his book put like psychiatric neuroethics. Psychiatric neuroethics. Psychiatric neuroethics examine how we understand and treat mental illness, considering our knowledge of the brain, the mind, our body, the environment, and what ethical obligations and social values ought to guide us. In this evolving landscape, organizations like ICONN have emerged to catalyze international cooperation and ethical reflection. Together, these efforts remind us that brain health, mental well-being, and longevity are not merely medical or technical goals, but conditions for building more humane and just society. These three lectures will chart a course through these themes, sketching a neuroethical vision that spans local care and global policy, science, even spirituality, if you wish, lifespan, health span, mind, and society. Let me briefly present also this project. The International College of Neuroethics and Neuroscience is a newly formed non-profit organization dedicated to bridging science, ethics, policy in the realm of serious mental illness. Found in 2024, right? We found it last year in San Francisco. And ICONN grew out of concern for people living with disorders such as schizophrenia. And I really touch with my eye and my heart and soul the burden of this disease that causes homeless people fighting with this disease. Schizophrenia, if you are going to hear about schizophrenia, affect around, Professor Sal could correct me, around 0.71% of people globally or more. But its repercussions extend far beyond prevalence. In many societies, people with schizophrenia are disproportionately represented among the homeless, the incarcerated people, and the socially marginalized. Recognizing this crisis, ICONN's founders, including clinicians, scholars from psychiatry, neuroscience, law, philosophy, set out to create an international platform to confront these challenges holistically. I guess this is the unique of ICONN, the word holistically. ICONN's mission is eloquently summed up. I invite you to visit our website. Is eloquently summed up in its founding statement: to integrate science, ethics, and public policy for healthy, sustainable, and equitable human flourishing. In practice, this means uniting researchers, clinicians, ethicists, and advocates around shared goals. We work to advance the understanding, treatment, and ethical care of people with schizophrenia. The organization emphasizes a human rights perspective. Mental illness should be treated as a medical condition, of course, not a crime or moral failing. To that end, ICONN actively challenges the criminalization of schizophrenia, of the people with schizophrenia, or affected by schizophrenia, advocating for reforms so that people with psychotic disorders do not end up in jails or asylums for lack of appropriate care. This summarizes, I guess, some of the ICONN's global impact, that our vision extends beyond advocacy to building practical coalitions and system challenge. As its founder state, ICONN envisions a neuroethics not confined to academia, but capable of impacting society, protecting the most vulnerable, and promoting a culture of respect and care. This vision reflects the idea that scientific research on the brain must go hand to hand with social justice and ethical responsibility. And for instance, ICONN hosts international convening, such next Monday and Tuesday here. We'll hold this global colloquium here in Rome, a two-day event with neuroscientists, psychiatrists, legal scholars, and ethicists. And we will deliberate on best practices for people affected by this tragic neurodevelopmental disorder. These meetings are designed to foster interdisciplinary dialogue. It's like, I guess, a real exercise of this interdisciplinarity that is not just speculation, is like bringing some concrete forms to help real people that are struggling with these problems. Likewise, ICONN promotes collaborative research agendas aimed at improving life outcomes for people with severe mental illness. So in March 2025, Rome played a host for the first ever Vatican Longevity Summit, a high-profile meeting convened by the Pontifical Academy for Life under Pope Francis' patronage. This summit, part of the Catholic Church 2025 Jubilee Year of Hope, we're still in the Jubilee of Hope, brought together Nobel laureates, professors in medicine, for example, Professor Yamanaka, one of the great leaders in the regenerative medicine, and in chemistry, Professor Ramakrishna, leading gerontologists, neuroscientists, ethicists, and heads of state. Its aim was to tackle one of the crucial challenges of our time, promoting healthy, sustainable, and integral aging. In other words, the Vatican recognized that as humanity lives longer, we must ask how to ensure those extra years are lived with healthy, meaning, and dignity. Bishop Vincenzo Paglia, past president of the Pontifical Academy for Life, framed in March that the issue in strictly moral terms. As he said, longevity should not be seen simply as a biological goal, but as an opportunity to enhance the elderly in the social context. The elderly are not a burden, but a valuable resource. Their experience and wisdom represent an irreplaceable cultural and human heritage. And also Pope Francis addressed message to the Vatican Longevity Summit in March. And we are working for the second Vatican Longevity Summit will be next year, May 25th, 26th. And so the implication is clear. How a society treats its older members is a measure of its humanity. of its humanity also. And so there's a 6 pillar of brain health apply in this situation. Nutrition, exercise, sleep, cognitive stimulation, stress management, social engagement as practical foundations for maintaining cerebral well-being. And so we developed this platform also in the Vatican because we are interested also in the ethics and the models of longevity today, as we did in 2020 with artificial intelligence and the so-called Rome call for AI ethics that the Pontifical Academy for Life developed. Now we want to tackle this topic of longevity and mental health in the same way. At the nexus of neuroscience and bioethics lie this psychiatric neuroethics, the study of ethical, philosophical, and policy questions arising from advances in psychiatric research and practice. So there's a lot of questions that Walter Glennon also framed in his book, Psychiatric Neuroethics. And he's very happy also, maybe he could collaborate with us in our next step for the future of ICONN. As Walter Glennon said, psychiatric neuroethics lies at the intersection of psychiatry, neuroscience, and philosophy and law. It encompasses both the ethics of neuroscience. This is very interesting because neuroethics divide in two: ethics of neuroscience and neuroscience of ethics. This famous partition of the neuroethics was structured by Adina Roskis in 2002. But the neologism of neuroethics goes back to 1973 to the neuropsychiatrist Annalise Alma Pontius. So these terms encompasses both ethics of neuroscience, for example, the risk and benefits of brain research and therapies, informed consent and protection for participants, and the neuroscience of ethics, how neuroscience must inform our understanding of decision-making capacity and moral cognition. Crucially, it also recognizes that psychiatric disorders can harm people by destroying the content of their mental states, impairing their will, and altering their identities. I will stress this in my last part, my talk at the end. So this is like our global mental health crisis, as you will hear soon, Professor Stahl. And also there's some organization, the World Health Organization, the United Nations mental health frameworks. But I want to conclude this presentation with this introduction. This is with this neuroethical vision that we want to foster in our work and our mission, I guess. We have seen that caring for the brain and mind at the global level demands an integrative approach. ICONN represents one part of this mosaic, a coalition of experts striving to translate science into compassionate policy, ensuring that even the most vulnerable people with schizophrenia are not abandoned. And the Vatican Longevity Project also represents a moral call to view aging not merely as a medical issue, but a human opportunity, where ethical values shape how we live longer. Psychiatric neuroethics in general reminds us that every innovation in neuroscience and longevity must be guided by fundamental principles. Autonomy balanced with care, not just autonomy, but autonomy balanced with care, and also life first. You can say, no? Life first. We are not in a political. Life first. Scientific progress balanced with justice, and research balanced with respect for personhood. Our responsibility as neurobioethicists and global citizens is to connect these stands. We must also ensure that world leaders and communities hear that mental health is indispensable to any vision for longevity or of longevity. Science alone cannot answer how can we all live longer, happier life without embedding that science within frameworks of rights, solidarity, and meaning. Brain health, mental health, longevity are not only clinical goal, but the condition for building also inclusive, more humane society. This is a profound insight. The way we manage mental health today will shape the future of our society in the decades to come. And so also I echoed ICONN's founding principle, placing the person at the center in all their dignity and complexity, right? In every policy we propose and every therapy we develop, let us remember the individual human story, the mother, the father, the student, the grandparent, who deserves a life of meaning. By nurturing brains and hearts alike, by speaking across disciplines and culture, by holding to global standards and shared values, we can answer the challenges of psychiatric care and longevity together. So thank you for being here, for joining us this afternoon. And now the structure of this afternoon is first, we will hear about the situation from one of the greatest psychiatry and neuropsychopharmacologist, Professor Steven Stahl. And I thank Professor Stahl. I met him in 2017 in Lucca. And I'm very glad to God to have met him and to start this reflection dealing with these topics of care for people and care for people that suffer a lot. And they bring, Stephen and Catherine, they brought me in the, I want to use this phrase, in the, like our Italian father of language, Dante, wrote the Divine Comedy. No, the first part of the Divine Comedy deals with the best, the ugliest place in creation, hell, right? And so we visit last May the Twin Tower Correctional Facility in Los Angeles. So I saw with my eyes terrible situation in Skid Row and in jail of people that suffer psychiatric disorders, and of course through this impairment they become sick and they commit some crimes. And so thank you for being here. And so first, Professor Stahl is going to go into the topic and explain with his brilliance and deep understanding of this, the neurobiological part of the disease, etc. And after that, Dr. von Burtur going to the policy part and also the difference between different types of political and social architecture, right? And so thank you. And I give the floor to Professor Steven Stahl. Please, an applause.
So thank you. And it's a great honor to be here and to take the next step in our collaboration. I'm going to talk about what's wrong with the people that are on the streets and in the jails and have all this behavioral problem. Are they evil? Are they sick? Are they making a choice? Many people have their own theories, but one of the problems that I have discovered in this collaboration is that those of us who work on the brain and treat this illness live in a bubble. The bubble is that we all believe there is an illness and we all believe that it's treatable. But when you step outside this bubble, you find out that most of the world doesn't believe that. And so I have two parts of my talk. One, is serious mental illness a brain disease? And number two, do we have treatments that work? And we are opposing people who believe the answer to both of those questions is there's no illness and the treatments don't work. So therefore, let people live on the streets, eat out of dumpsters until they get disturbed and hit somebody. Then you can arrest them and put them in jail, and then you can treat them for a while and then release them back to the streets, and they go back and forth. This is not humane. In Los Angeles alone, there's 75,000 homeless people. Many, if not most, have this illness. So, schizophrenia. How do doctors like me, I'm a psychiatrist, I'm a psychopharmacologist with a PhD as well. How do we make a case this is a disorder? We say, hey, it's in the psychiatric manual called the DSM, Diagnostic and Statistical Manual, and it's in the International Classification of Disease, ICD. It wouldn't be there if it didn't exist, right? So that's enough. We have criteria. We can diagnose it. What's the problem? Furthermore, the symptoms can be quantitated and tracked with validated rating scales. We can tell how bad you are. And by the way, this illness has been around for centuries. Do you know that about 1% of Italy is schizophrenia? 1% of California is schizophrenia? 1% of Eskimos? Of people who live in the jungles of Amazon? 1%. What's going on? There's an illness in society. It represents, and 1% for as long as there's been humanity, we've had this. So what's the big deal? Of course there's an illness. Well, when you actually start talking to people outside the bubble, they say, Dr. Stahl, you're wrong. There's no such thing as schizophrenia. Why? First of all, this is a concept made up by psychiatrists and the pharmaceutical industry for their mutual enrichment. We can make money by treating the patients, get a salary, and the drug companies can make a profit. That's all it is. And psychosis, which is basically the symptom profile of schizophrenia, what do I mean by that? Delusions, which are false beliefs, paranoid usually delusions, and hallucinations, hearing voices that are not there. If you get psychosis, it can be once in a lifetime for, well, I don't know what reasons, and then it gets better. What are you talking about, an illness? And the range of symptoms in the clinical course, my gosh, there's mild, there's moderate, there's severe. It's so crazy across you can't even make it into a disease. How can something with this much variability be real? And furthermore, I'm going to argue as a person who once was diagnosed with schizophrenia, if that's who I am, some of the people who oppose us say that, I have lived experience. And I know that I was called schizophrenia, and I'm not schizophrenia, so there's no such thing as schizophrenia. And therefore, all the psychiatrists want to do is control me. They're just nasty people. They sit around all day and they just want to say, my behavior is unusual, so we don't like it, we're going to control that. And besides that, the environment causes this. It's poverty, it's bad parents, it's child abuse, it's drugs. It's not the brain. And actually, this are really creative people, mostly. They're just misunderstood. So this is what people say. So we are trying to get together to say, what's wrong with us as experts that we don't communicate better? This is so obvious that it's an illness to us. It's just astounding to me that we don't convince people. So what are we doing? So here's some technical things. We know that it's an inherited, it's complex, multidimensional. Syndrome, which means collection of symptoms. Psychotic, but also negative and cognitive symptoms, mood symptoms, motor manifestations. And it goes up and down and up and down, waxing and waning, remitting and relapsing. And here's one of the clues that will help establish what Father Carrara is going to talk about in terms of the ethics. Anosognosia. Say that 3 times. Anosognosia. What does it mean? It means the inability to have an understanding that you are sick. It's a very interesting problem. I don't think I'm sick, and therefore I don't need treatment. And besides that, I don't think the treatment works. It's a very funny kind of component of schizophrenia. It's heterogeneous, it's not a single disease, and there's no single common pathway. There are lots of genetic risk factors, maybe thousands of small genetic variations, and there's some overlap with these genetic variations with other serious illnesses, such as bipolar autism and ADHD. And environmental risk factors are sure, yes, absolutely. Urban residence in childhood, migration is a horrible one. Older paternal age, cannabis use. One of the big triggers to people with risk of schizophrenia who turn out to have schizophrenia, the manifestation of that risk is you smoke dope. Boom. And then it triggers schizophrenia. There's estimations that if there was no high potency cannabis in the world, that maybe half of the cases of schizophrenia would never get triggered. So we also know that there are brain alterations in a bunch of brain circuits. Your whole brain is dying. It's degenerating. You're losing gray matter progressively over time. So this is a graph of the course of the illness. You start with a level of functioning pretty high. Most patients, before they have schizophrenia in their early adulthood or teens, have 1 to 2 standard deviations of IQ, cognition lower. That's a signal. And then they may have some oddness, but then all of a sudden, boom, they think the CIA is after them and they're paranoid and they hear voices and they have a first episode. And then they wax and wane until they get into their 30s where they have a chronic relapsing course. This is the classical course of schizophrenia, especially when it isn't treated. You know, this could be the course of cancer if it wasn't treated too. But for some reason in this world, we treat cancer and we don't treat schizophrenia. If you actually had a brain tumor and you didn't think you needed to be treated, you'd get treated anyway. We've got a neurosurgeon right here. You would say, you don't know what you're talking about. We're going to save your life. But in schizophrenia, I don't have schizophrenia, fine, go away. You don't have to be treated. That's we do this. What is wrong in the brain? If you do a PET scan that measures dopamine, there's a specific region in the brain where dopamine is too high. It's not 100% of the patients, it's maybe 2/3 of the patients. And you can actually literally see it on the left. You see that brain region has got more red hot dopamine represented on the left than on the right. That's all it takes to be delusions, hallucinations, and schizophrenia. Guess what? This brain looks the same if you're bad bipolar mania. It looks the same if you have cocaine or amphetamine psychosis. Psychosis is psychosis. Schizophrenia is the most common cause of the psychosis. And it correlates. The more psychotic you are, the more dopamine you have. And it has led to our treatments, which are basic, I'll tell you about in a second. They all block dopamine. Blocking dopamine makes you better. It doesn't cure you, but it does help the symptoms. Here is an idea of anosognosia. I'm not sick. I don't need help. It's a neurological term in 1919 by Babinski. He coined it to mean I'm not aware of my neurological deficits. And sometimes stroke can cause this. Certain brain lesions can cause it. We used to think it was in the back of the brain posteriorly, but more recently we think it's actually located in the prefrontal cortex. And so the research findings ever since the 1970, what percentage of patients with a diagnosis of schizophrenia have anosognosia? And the short answer is it depends on which criteria you use for schizophrenia, because they changed over the last decades. But when you studied it in 1973, 80%. 1986, 80%. 1989, not only 80%, but it doesn't get better. Now, that is actually something that needs a lot more investigation, because we don't really know how well treatment could help your anosognosia. We do know that when you treat schizophrenia, their insight into other things gets better. What else do we see? The frontal lobes are involved in neurological disorders. So that's why we think this is a neurological disorder. Now, in 20 different studies that compared the brains of schizophrenia patients with and without anosognosia, guess what? All found something was wrong with the brain structurally. And it was a variety of anatomical structures, mostly in the front of the brain. And in 3 of the studies, subjects had never been treated with medication. One of the arguments is, oh, this is all caused by the drugs. Schizophrenia patients have both schizophrenia and treatment. And so the people who do not like what I'm talking about say, it's not the schizophrenia that causes it, it's the drugs. But there are ways with large populations to subtract out the effect of the drug and see, is it due to the illness or the drugs of treatment? And it's really due to the illness. So another way that this was done by an expert called Xavier Amador, not to ask, do you have anosognosia or not? Yes, no. He actually said, is it moderately, I'm somewhat aware that I might be sick, I'm completely unaware, or I am aware. And he found that about a quarter of the patients had some awareness, and about a third of the patients were completely out of it, and about 40% of them actually knew it. And mostly what we're talking about here today, the policies are going to be directed towards those who are unaware. If you are aware, there's a good chance you do accept treatment. One of the arguments about schizophrenia is that some of the patients come to clinic. Some of them say, I'm sick. Some of them take their medicines. We're not talking about them. We're talking about the guys that live in tents on the streets of Los Angeles until they get arrested and go to jail because they don't take medicines. So they're unaware of all these symptoms, and that's the group, seriously sick people. And so we know that the DSM, which is the psychiatrist's manual, states that unawareness is a symptom, but we don't emphasize this enough in our teaching, and that we need to start doing that. So it's common in some of the other disorders, but it's, guess what it predicts? If you don't have an illness and your drugs don't work, do you think you take your medicines? No. It leads to non-adherence. So I'm a psychopharmacologist, and I get very frustrated. Why do I have all this medicine if nobody takes it? If you have cancer chemotherapy, people do take it. So anosognosia, in summary, is stable over time. It doesn't improve a lot with treatment. It's the predictor of refusal of treatment, and it also predicts severity, number of hospitalizations, poor functioning, and it's a common barrier to working. So we need to actually focus our efforts today of policy and ethics on this group of people. How do we communicate more effectively is one of the questions. I want your insight. I want you to look at this and say, well, Dr. Stahl, you're missing the point. One of the things that I would say, propose to you, and maybe there's better ways, is, ladies and gentlemen, there are structural and functional neuroimaging abnormalities in the brain you can see. That shows you that's an illness. This illness exists in the same proportion in every country for centuries. How did that happen? Is that an accident? It seems to be in our gene pool. I don't know why, but it is heterogeneous. Treatment should emphasize the patients at the more severe end of the spectrum. And those are the patients that are at risk for more of the brain degenerating, more relapses, and guess what? Premature death, and I'm going to talk about that next. So, not now, but when we have a questions and answers, I'm going to ask any suggestions. Now, the next thing is, of course, the drugs don't work. What? That seems crazy to me. So how do I make the argument that they work? Which, by the way, is singularly ineffective. Do you want to know what the ineffective argument is, but everybody in the bubble believes? Well, antipsychotics have FDA approval and government approval. They're safe and effective. That's enough, right? It wouldn't be safe and effective if they didn't work. Randomized clinical trials have statistically significant improvement over placebo. That's the way we know a drug works. You tell that to a parent or someone who's taking this medicines, what's statistically significant? It has no meaning to them. And this is the scientific gold standard of proof. So I've told it to you. Now I'm done. I don't need to talk anymore. When I go to court, Dr. Warburton goes to court. Our doctors in our hospital system, have 5 hospitals in California that she's the head of. I work in that. About 7,000 patients, about 300 psychiatrists. We go to court and say, Jim over here is sick. He won't take his medicines. Will you give me an order to make him take his medicines? And the people who advocate for him say this: they don't work. Why? Antipsychotics only prove symptoms by 20% on your stupid trials, Dr. Stahl, for approval. What's that? Big deal. And many patients don't even get that. That's the median. How about the people that are below the median? 20% improve is not impressive, and there's nowhere close to symptom remission going away. And this gain isn't worth it. Look at the side effects. If only 20% improvement occurs, and it doesn't even touch negative symptoms or cognitive symptoms, doesn't improve social functioning, particularly in the trials that you're looking at, Dr. Stahl, maybe we can forego this treatment. What if Jim doesn't want to take his medicines? Big deal. No harm, no foul. And the only trouble is you take them, you get side effects with minimal benefit. Nobody rational would agree to this, right? It's rational to refuse medicines. What's Dr. Stahl saying they work? Randomized clinical trial, 20%, statistical significance. Ha! And guess what? Judges hear this argument. They say, you know what? It makes a lot of sense to me. You may refuse treatment, Jim. Go back to your tent on the street of Los Angeles and live a happy life. Antipsychotics are overprescribed by these corrupt doctors in their industry anyway. They also say antipsychotics impair your brain function. They don't help it. They blunt your emotions. They cause brain degeneration themselves, weight gain, irreversible movement disorders. Naturalistic studies, some of them actually suggest better outcomes in unmedicated patients. I can show you some studies that you can always give your medicines later and get the same symptom relief. And if you actually have one episode of psychosis, about 21% of the people never have another one. So why treat them? Why don't you just wait and see what happens? By the way, if you have 2, about 11% approve. So why treat them? And the answer is we don't. You treat the people who have lots of episodes and are very, very sick, but don't tell them that. Subgroups of schizophrenia who stop their antipsychotics, they will say, with some studies, are less likely to be psychotic and experience more symptoms of recovery compared to those who are medicated. You can find lots of studies out there. If you cherry pick in front of a judge, you can take not the balance of evidence. There's so many studies out there, you need to look at hundreds of studies and say, what's the balance of evidence? And not cherry pick. First episode patients can go into remission, and you can stop in medicines in those patients. Okay, what's the argument against that? I'm going to show you here some data very quickly that the down means better. So these are naturalistic studies with different treatments. So we can give pills for psychosis orally. And if you do that, they reduce, you're stopping your medicines, you're compliant in the first graph. You have fewer admissions to the hospital, which are total, and you have fewer involuntary admissions because if the police bring you in and you're absolutely naked and running around and dangerous, they can involuntarily do it. And it reduces suicide attempts. I don't know if you know this, but we have this thing called long-acting injectables. You can give a shot of a drug that lasts between 30 and 90 days. I got a question for you. How many of you take medicines every day? I take medicines every day. It's hard to take medicines every day. Is it easier to make 30 decisions to take your medicines every 30 days, or one decision to take your medicine every 30 days? And so you can see the blue lines improve all this in treatments, reduces hospitalizations, and reduces suicide attempts. Why? Because they're on the medicines. Every 30 days, you can find the patient and give them another shot. So guess what? If the same doctor treats you over time, you get a better outcome. Have you gone to doctors with you or your family? And isn't it true that if someone knows you and you go back and have the same person, that you get better care than if you see a new person every time you go in? That's all this graph is showing you. And at 5 years, those patients who have the same doctor for 5 years, look how much better their outcome is. They just don't go back, probably because they trust that, I'm not sure I'm ill, I'm not sure the medicines work, but this is a good doctor, and so he or she thinks it works, so I guess I'll do it even though I have doubt. That's why they do it. Do you like this curve? If you don't take your antipsychotics, you die 30 years early. It's not subtle. What do you die of? Half of those deaths are from suicide. Living on the streets is so horrible. Being rearrested and put in jail and beat up and all the things that happen to people is such a miserable life that 15% of patients eventually kill themselves unless you're treated. So the risks of stopping medication will be shown on this graph. So if you take your medicines, it's the blue line. If you stop them, it's the green line. That's how often you die. And if you take the red ones and then stop them, that's the red line. Guess what? Antipsychotics work. The one thing here, I'm going to show you the numbers. It doesn't matter if you really understand it because it's statistical. But what this says is that the acute treatment, if you look at the standardized mean difference in the far column of 0.43 or 0.51, two different studies, the bigger the number, the better the drug works. The smaller the number, the worse the drug works. So about 0.5 is for whether you give a drug and the symptoms go down. Now, the 0.92, that's if you keep taking the drug, you don't go back to the hospital because you don't get psychotic again. Big effect. How big? Well, you ever hear of a statin for cholesterol? Yeah, I take one. What's the effect size in me taking my statin in preventing a heart attack? 0.15. What if I take an ACE inhibitor, angiotensin converting enzyme, as an antihypertensive, keep my blood pressure down to prevent a heart attack? What's the effect size of that? 0.16. How about if I take metformin because I've got type 2 diabetes? 0.03, very small. And finally, what if I take aspirin to prevent a second heart attack after a first? 0.12. What does this show? Antipsychotics work better than aspirin, metformin, antihypertensives, and cholesterol drugs. Nobody knows that. Shame on me for not telling you before. And thanks to a colleague of mine who's going to be talking on Monday, he found this, and it just knocks my eyes out. This is amazing. Antipsychotics do work. Brain atrophy data. So the known structural brain abnormalities, including the reduction in gray matter, particularly frontal cortex, is due to illness or treatment. There's an argument. Go to court, Your Honor, drug's going to hurt him. No. It's disease-driven brain toxicity that's mitigated, not worsened by the drugs. Not completely reversed, but slowed. Schizophrenia is far more neurotoxic than its treatment. Antipsychotics don't shrink the brain, schizophrenia does. Antipsychotics may possibly even reverse some of the loss of your brain. And guess what? The longer you're sick in a relapse, the more your brain is lost. Antipsychotic exposure, whether sporadic or consistent, be better if it's consistent, it confers some neuroprotective effects. So don't delay treatment. Time is brain, ladies and gentlemen. I don't know about you. I'm not sure this has been proven, but if I had a choice, I'd rather have more brain than less brain. So that's what we're saying. The duration of untreated psychosis, for example, at the beginning of the illness, how long it's delayed until you take your first drug, it's huge as to what happens to you. So there's lots of studies of people who have their first episode of psychosis and they find out how long they've had it before they got their first pill. Prolonged delay is a critical window of missed opportunity because even months of delay contribute to more reductions of your brain. Wow. Poor outcomes are associated with hippocampal atrophy. Changes are evident even before transition to full-blown psychosis, suggesting that this is something that happens maybe even in utero. It may be silent during childhood, and something happens with the restructuring of your brain. There's an old thing, I don't know if you know this, but the brain makes about twice as many synapses as it needs between the ages of 6 and 16. And then around 16, it assassinates half of the synapses in the brain. If you don't believe me, you haven't had an adolescent in your house because you can see the restructuring of the brain right before your eyes. And we believe that's in that restructuring that it unmasks schizophrenia in the onset of the psychosis, late teens and early 20s. So prolonged duration of untreated psychosis, DUP, shows you that this illness needs to be treated. One size does not fit all. Everybody needs treatment forever. No, I'm not saying that. I try to say people with anosognosia who have severe illness, who are homeless, who don't know they're ill, they need to be treated. Every episode of untreated psychosis matters. The longer it's left untreated, the more difficult. So let's say we have cancer. Why don't we wait until it metastasizes to 2 or 3 different places and then we treat it? So if you treat everybody with cancer not until they're stage 4, how much good outcome are you going to have? That's exactly what we do in schizophrenia. We have a long delay till they first get treated, and episodes don't get treated a lot during a lifetime. Neuroimaging and real-world outcomes suggested that untreated schizophrenia is much more neurotoxic than drugs. And finally, untreated psychosis changes the structure of the brain neurodevelopmentally, but then it's neurodegenerative as well. First episode patients have widespread abnormality. The first time you have schizophrenia, your brain's already lower. So people have studied to disentangle the effects of the drugs with the effects of the illness. And we now know that the longer a patient remains untreated, the more likely they are to experience neuroanatomic brain degeneration, functional decline. And just like in cancer, treatment resistance, not good. So the difference as slight as weeks can make a bad outcome 5 years later. Now, it is true that patients who discontinue their meds successfully, and I've seen many of them, every psychiatrist has, they may represent a fundamentally different clinical phenotype with milder course of illness. Use lower drug doses, stop the drugs in these people. I'll be first in line to say, don't overtreat. But it doesn't mean because there are these patients that there aren't severe patients that do need treatment. So I ask you, and I finalize with this slide, I want your help. How can we communicate this more effectively? I think one of the ways I'm going to be a candidate to say is the effect size of antipsychotic efficacy is larger than that for major medical treatments. That's pretty convincing. Chronic cases have demonstrable neurodegeneration. You can actually see something in the brain going wrong. There must be something going wrong with schizophrenia. It's a real illness. And serious mental illness is life-threatening, shortened lifespan up to 30 years. It can literally torture people with frightening symptoms and rob them from adolescence for the rest of their life of a productive life. Antipsychotics save lives. Why would you not give things to people that save their lives because they don't think they're ill and they don't want to. And we have been ineffective in convincing judges and families and patients themselves to save their own lives and take their medicine. So I leave you with that to ponder and help us. How do we say schizophrenia is an illness? And how do we convince people that the drugs work?
Thank you. So think about this question for the interaction with us. Now, we move from neuroscience to policy now. So Dr. Catherine Warburton is a doctor, is a psychiatrist, and she's in charge of this big structure that I had also the privilege to visit in Napa Valley, the California State Hospital. And so we visited last year this structure, and she's very involved in changing policy and to also to rethink the policy imply to for improving the life of these people, right? So she's now delivering us this talk dealing with policy for these psychiatric patients. And also she studied a lot the difference between different style of approach the problem in different countries, especially US and Italy. Last year, right? We visit also Bari and also a jail, and we visit also our REMS structure, right, here in Italy. And so thank you to be here, Catherine, and the floor is yours.
Grazie, Padre. Buonasera.
She's learning.
I'm learning Italian. Thank you for having me. I'm going to talk a lot about the differences between the state where I live, California, in the United States, and your beautiful country, Italy. You don't just have incredible food and beautiful vistas, but you also have some darn good mental health policy. And we've learned about that through our relationship with Father Carrara and visiting facilities in Italy. And I'm going to talk a little bit about what is a humanitarian crisis in the United States and compare and contrast it in terms of policy with what's happening here in Italy. I am the medical director of an extraordinary large forensic hospital system. You probably don't know what that is because Italy outlawed state hospitals and forensic hospitals in 1978 with the Basaglia law. But in the United States, we have thousands of individuals who have schizophrenia or psychotic brain illnesses who are locked into forensic facilities after they've committed a crime. California, we took Father Carrara. I remember sitting in this room a few years ago trying to explain to him what was going on in the United States. And I am quite sure you did not believe how bad it was at the time. But we were able to take Father Carrara to Los Angeles this last spring and show him what's going on in one of the richest cities, in one of the richest states, in one of the richest countries in the world. And just to give you a sense of that in terms of finances, in California, we have something called the California Mental Health Services Act, where we tax people who make $1 million or more every year, 1% of their salary, and we put that money and we dedicate it for people who are supposed to dedicate it for people who have very, very serious brain illnesses. That has garnered over the last 20 years, $35 billion that we've spent in California, ostensibly to treat people with the most serious brain diseases. This fund garners about $3 billion a year for this population, and that's over and above the usual state and federal funding streams that we have for medical care. So how is that working for us? I'm going to talk a little bit about what's going on for individuals living with schizophrenia in California. This is actually a picture of what we call Skid Row, which is blocks and blocks and blocks in downtown Los Angeles of individuals who are living with psychotic brain illnesses, who are out on the streets, untreated, as Dr. Stahl said, being tortured by delusions, paranoia that people are out to get them. That's a primary reason why people don't want to move inside, because they're afraid to move inside, because they become paranoid about the people living near and around them. And hallucinations, which often come in the form of auditory command hallucinations that order people to live outside, or tell people you can't go in there, those people are going to harm you. So these symptoms are actually torturing these individuals, and they live on the open street in poverty, and most of them are starving. And this is the result of our $35 billion investment that we've made in the last 20 years in my state. There we go. So here's another picture of downtown Los Angeles. This, as I mentioned, goes on for blocks and blocks. This is a very common sight in California cities to see unsheltered, untreated individuals living in poverty and eating out of trash cans. So we presented, the three of us, hard to believe that this was a week ago, but the three of us were on a stage in San Diego, California. And one of Dr. Stahl's colleagues emailed him this after we finished speaking. He said, "As I've walked the streets of San Diego, my enjoyment has been shattered by the fact that the city is like one huge outdoor psychiatric inpatient locked ward. I haven't seen so many cases of end-stage psychosis since the summer of 2024, when I observed a similar landscape of horror on the streets of Seattle. My eyes have filled with tears more than once over the last couple of days as I've seen these incredibly psychotic, broken down people. I try to see them as the children they were, but it's almost too much to bear." And we witness this every day, and that's why we have formed this nonprofit organization, and why we have sought some divine advice from Father Carrara. I'm going to talk a little bit about outcomes. As Father Carrara mentioned, people living with schizophrenia make up less than 1% of our overall population, but they make up 20 to 30% of our homeless populations, 15% of state prison populations, and 24% of jail populations. So in the United States, a jail is like a remand prison where you go before you actually stand trial. This is a picture that was shown at a conference that I was at in June. So in June, we took our traveling roadshow to Dublin, Ireland, to an international conference of forensic psychiatrists. And I went to the keynote talk that was being delivered by a European legal scholar, and they were debating the merits of different types of definitions for dignity, because the European people really are concerned that their forensic populations experience dignity. And so they're really hammering out the finer points of how to do that. And I'm sitting in the crowd, and then they said something like, "And then there's the United States." And the entire crowd laughed cynically, and I started slinking down in my chair, trying to adopt a Canadian accent at that point. And then they showed this picture as the epitome of a lack of dignity in forensic populations. And this is a picture of a facility that I was the medical director of in Salinas Valley, California. I was not responsible for these cages. In fact, we were not allowed to call them cages. We were supposed to call them therapeutic modules. But these are the cages where, when individuals who are not living on the open streets get arrested, they are kept in these cages when they are incarcerated. I'm going to talk a little bit. Policy is not nearly as exciting as neuroscience or neuroethics, but it's what's driving this problem. So I'm going to talk a little bit about mental health policy in the United States, which has been a cyclical pattern of failure. And then I'm going to, in a few minutes, compare and contrast that to what's happening here in Italy. So in the middle of the 1800s in the United States, people who had psychotic brain illnesses were kept in cages or chained to walls or locked away in jails. And this humanitarian crisis caused a lot of moral outrage in the middle of the 1800s. And so that was remedied by the asylum movement, building these beautiful Gothic castles where individuals who had psychotic illnesses could go exalt in nature, experience spiritual nourishment, and be well taken care of by the doctors and nurses who lived on grounds with them. They would do art, they would farm and eat produce that they grew themselves. It was kind of the high point of mental health treatment in the United States 200 years ago. What happened, as you can see in these orange bars, is those asylums became very overcrowded. 50 years later, there were 150,000 people locked away in those asylums. And by the middle of the last century, there were 500,000 Americans living with psychosis and other disorders who were crammed into these aging facilities. And it became such a outrage, again, moral outrage at the conditions these individuals were living in, that we implemented something in 1964, followed up in 1968 in California, to change the laws to make it almost impossible to lock someone in a psychiatric hospital or treat them against their will. And that was called deinstitutionalization. And here in Italy, your Dr. Franco Basaglia was doing kind of the same thing, but he did it right and we did it wrong. And I'm going to talk a little bit about that in a few minutes. So what's happening in the United States now as we enter the middle of this century, almost 100 years later, after the deinstitutionalization movement began, is we are again facing a humanitarian crisis where individuals living with serious mental illnesses are cycling through the open streets, our jails, our prisons, my hospitals, and not getting any type of sustained treatment. And so policy changes are again afoot in the United States. What's happened is something called the incompetent to stand trial crisis. And in short, it is unconstitutional in my country to allow someone who's very psychotic to stand trial if they don't understand what's happening to them or they can't rationally assist their attorney. That's considered unconstitutional. These are the same individuals who are deemed competent to make their own medical decisions and to choose things like living outside or starving because that they don't know that they're ill. But once they get into the criminal legal system in my country, they're not allowed to stand trial if they're incompetent. So they get sent to our state hospital system. We medicate them. We just published a paper. We restore 88% of individuals to competency using the medications that Dr. Stahl was talking about. And then we send them on to trial to face their charges. A significant number of those individuals are released right back out into the community. And so these papers, which I'm going to just run through quickly, are indications in the academic literature of this problem. This is a British psychiatrist named Lionel Penrose, and in 1939 he published a paper where he studied Western societies, and he noted that countries that have a lot of people locked in their prison system had fewer people in their mental health hospitals, and vice versa. Societies that had a lot of people in their mental health hospitals had fewer people in their prisons, and this is called the Penrose effect. We started wondering about the Penrose effect pretty soon after deinstitutionalization. This is a Dr. Abramson from California who worked in one of the hospitals that I've worked in, one of the state hospitals. And when the LPS Act of 1969 occurred, it changed the paradigm for involuntarily treating someone to a dangerousness standard. So someone has to be either dangerous to themselves or others, or so incredibly disabled that they're essentially a danger to themselves to receive any sort of treatment. And so he started seeing individuals that had been at the state hospital showing up in his jail. And he actually was able to document 100% increase in the year after that act went into effect, and the increase of individuals who were so psychotic that they were not able to stand trial. And so he was concerned that the LPS Act may have unintended consequences in terms of reinstitutionalizing people through this involuntary commitment, through the IST commitment. This is another paper from 1989 showing that the IST commitments increased post-deinstitutionalization by an average of 20%, and that it was very, very positively correlated to deinstitutionalization. So you can see that Penrose effect happening. People left our state hospitals and started filtering into our jails and prisons. We've done a tremendous amount of research on this group of individuals who are being arrested on felony charges, which are the most serious charges in the United States. Those are the types of charges where people end up going to prison. Thousands of these individuals coming into our hospitals and increasing every year, year over year, 10 to 20%. So every year, 10 to 20% more individuals are getting arrested on felony charges who have psychosis. And so we've been able to determine that 67% of these individuals were experiencing homelessness at the time that they were arrested. The percentage of people coming in who'd been arrested 15 or more times went from 16 to 46% in 5 years. So we have individuals who are unsheltered, who are having more and more criminal justice contact. We have a system called Medicaid. We do not have the type of universal health care you have here, but we do have government health care for people who are very disabled or who are very poor. And we were able to look through our Medicaid data and found that almost half of the people who were coming into us who were psychotic and being arrested on serious charges had received no mental health services whatsoever in the 6 months prior to their arrest. And those that did receive mental health services were largely seen in our emergency departments. In fact, we have an emergency room physician flying from Harvard, from Boston, to our conference on Monday because the issue of untreated individuals overwhelming our emergency rooms in the United States has become a critical problem. There is a belief, I think, with some people in the criminal legal system that, well, at least if we arrest these individuals on felony charges, they go to our state hospitals and they get treatment. And that's true. We have incredible treatment. We have the best psychopharmacology director in the world. And like I said, we restore almost 90% of these individuals to a very healthy mental health status. But then we have to send them back to court to stand trial. 75% of them get their charges dropped or get time served, and 70% and walk right out the front door of the jail back to the homeless and untreated conditions. And 70% of them are rearrested within 3 years. So this is the current cycle that is manifest in the United States. So we had in the middle of the 1800s, people chained to walls. In the middle of the 1900s, we had people locked in asylums. And now here in the middle of this century, we have individuals who are doing this cycle of criminalization from the streets to the jails and back again. This has been described as a national crisis. This is happening in California. We're the biggest state population-wise in the United States. So we have a more obvious issue with this, but this is happening in at least 80% of the states in the United States. And it's important to note that the average age of these patients who are coming into us is 31 years old. So schizophrenia tends to manifest age 18 to 24. And so this is the condition that these individuals are in, a decade into their disease, to Dr. Stahl's point. So this is a de-identified case. This is a typical case that we see in our state hospital system. This was a 37-year-old homeless man who was at a fast food restaurant in one of our California counties, and he was very psychotic, screaming about the devil, and people got uncomfortable, so they called the police. The police came and asked him to step outside, which he did without any violence or issue. And when they got outside, the police put their hands on him. And when they put their hands on him, he began to struggle violently. And through the course of that episode, it became clear that he thought the police were the devil, and he was paranoid that the devil was trying to kill him. He had actually taken out his own eye because the devil, through auditory command hallucinations, had told him to. So when the police put their hands on him, he did not realize they were the police because he was delusional. He thought they were the devil. He actually tried to call the police on an imaginary phone. So he was literally in his mind fighting for his life with the devil, and he fought for his life, and he injured a police officer. And that's how he ended up with felony with injury on a police officer and resisting an executive officer felony charges. So this shows you how the positive symptoms of a neurological condition are being mislabeled as criminal behavior and driving this crisis in the United States. This is one case. This represents about half of all of the cases that we see. 10,000 people we treat a year are getting arrested under these types of conditions. So this is what we call the criminalization cycle, where individuals who develop psychotic brain diseases are not treated. They end up unsheltered in our communities. They get arrested because they are unsheltered and untreated and symptomatic in public, and they have an episode like the gentleman I just told you about. In many states, they're waiting sometimes over a year in jail to come into a state hospital to be restored to competency so that they can stand trial. They are medicated, restored to competency. They are sent back to court. Most people have their charges dropped. They walk out the front door of the jail. They go back to the untreated, unsheltered condition. Their brains are being destroyed by their illness, and they get rearrested and come back into us. So this is, we've documented this is what's happening to people living with psychotic illnesses in my country. This is just a study showing the national nature of this crisis, showing a 74% increase in forensic patients in state hospitals, being largely driven by this increase in incompetent to stand trial patients. And this is actually before the crisis really began. The crisis really began in 2014. So we're anxiously awaiting updated data from this research institute. We think it's going to show some dire increases. So Dr. Stahl mentioned this term, anosognosia, and I'm going to sort of switch into the policy analysis now. And he showed you a bunch of studies that showed a lack of awareness of illness is very common, and some studies show it's as high as 80%. I was a little more conservative in my slide and said 60%, but at any rate, the majority of people who experience schizophrenia spectrum disorders are not aware that they're sick. Well, how does that play into the crisis? Well, in the United States, we have something called informed consent, where in order to provide a patient with treatment, you have to assess their medical decision-making capacity. And after you determine that they're competent to make a medical decision and have capacity, then you get informed consent, and then you can proceed with treatment. So in order to get informed consent, an individual has to have medical decision-making capacity, which means they have to know that they're sick. And in the United States, our laws don't allow us to treat people who lack medical decision-making capacity if they have schizophrenia. We have to wait till they're dangerous. So this impossible task of getting informed consent from someone who doesn't know they're sick and therefore lacks medical decision-making capacity, in our opinion, is at the core of what's happening to young people who develop psychosis in our country. In general, I can recall this when I was a resident, having a floridly psychotic person walk into the emergency department, and if they say, "I'm not going to hurt myself or anyone else," you let them walk right back out the front door of the emergency department and say, "Well, there's nothing we can do." So this brings up for us some medical ethical considerations. We do have medical ethics. The first principle of medical ethics, we take an oath to do no harm, non-maleficence. We also are compelled by our medical ethics to do well, to treat people well, to do good, to make things better for them, and that's beneficence. We also have a concept called justice, where we're supposed to treat people the same way. And the reason justice is so important in schizophrenia is because we treat schizophrenia different than any other disease. We do not use a medical decision-making standard for treating people who don't know that they're ill with schizophrenia. So there's a justice issue. In addition, we spend $36 billion of mental health resources to not treat people. So there's some serious justice issues there. I touched on capacity. And then finally, there's autonomy. And I don't know if it's because we're Americans and we just think autonomy and self-determination are the most important things in the world, but our entire mental health system is based on the concept of autonomy, and we value autonomy in psychotic illnesses above all of these other medical ethical considerations. Something's happening in our country. There was an executive order that was issued by our federal government to clean up our streets, where the federal government is ceasing funding for programs for individuals who are living on our streets and trying to motivate states to reinstitutionalize people. And so we're at risk of not striking the balance that you all have struck in Italy, where you are treating your citizens who have schizophrenia in your communities, but we're at risk because we relabel those symptoms of mental illness as criminal behavior, like the gentleman I told you about, of having another swing where in 100 years we'll have people locked up in institutions again. And our point is, it doesn't matter if someone's in an institution or in a prison or on the street, the issue is neglect. And our policies allow us to neglect people if they're not quote unquote dangerous. So here's just a look at the different policies. So in 1967, the LPS Act in California kicked off this deinstitutionalization movement. And it basically created that dangerousness standard where even if someone does not know they're sick, if they're choosing to live outside, if they're choosing to starve and eat out of the trash can, even if they don't know they're ill, you cannot give that person treatment. The other piece of federal change that happened with our Deinstitutionalization Act is local governments were incentivized to keep people in the community because they would get federal funding if they did. And what that basically means is if an individual is in the community, they are a local jurisdiction's responsibility until they get arrested. And once they get arrested, they're the state's responsibility. And so there's a fiscal incentive in our country to allow people to get arrested. And that's in stark opposition to the Basaglia Law of 1978 that eliminated the dangerousness standard and said, no, we're going to use a medical necessity standard and treat this like every other disease. The Basaglia Law outlawed state hospitals and state forensic hospitals and guaranteed a right to mental health care. And I've toured your mental health system in Puglia, and I've toured your mental health system in Trieste, and I believe that your policies are far superior and resulting in much better outcomes. One thing that's happening right now is the World Health Organization is lobbying governments to not have any type of medical necessity standard for involuntary treatment, saying that coercive practices are abuse at best and torture at worst. And that's one of the reasons why we as physicians and ethicists need to be discussing this in a thoughtful and science-based way. These are just models of care. This is if your child is 16 and develops diabetes, this is the standard of care for diabetes in the United States. If your child is 16 years old and develops leukemia, these are some guidelines from Australia for the treatment of leukemia. And we have no such model of care for when your 16-year-old child develops schizophrenia. And that is one of the missions of our college. And then finally, this is my last slide, but this is what's happened to people in the United States and in California. We're not just treating the psychotic illnesses that Dr. Stahl mentioned are so treatable. By the time individuals come to us, they have been living on the open streets and incarcerated. They're experiencing severe trauma. We've done studies, they have very serious cognitive issues from years of untreated psychosis. They have really difficult substance use disorder issues. One of the things we're finding out is people are abusing methamphetamine in order to stay awake at night because they're unsheltered and they're afraid and they get victimized at night. And that's one of the drivers of methamphetamine abuse in our population. And people cycling through the criminal justice system pick up criminogenic behaviors in order to survive in those systems. So by the time they come to us, this is all of the aspects of neglect and harm that our system has done to people that we have to treat in order to get them healthy. We're doing this to people. This is not a classic course of psychotic brain illness, and it doesn't have to be. So it's kind of a downer talk, but thank you for your time.
Thank you so much. And now we can ask, and so neuroethics, what's the deal about neuroethics? So now I want to use like 15 minutes because I want to have like time to interact with Dr. von Burter, Dr. Stahl. And so I made my introduction, and now I want to put and to stress the idea of neuroethics here, right? Especially a vision of neuroethics linked with what's happened in consciousness and free will of these people affected by schizophrenia. So I'm going to share my second presentation. So the failure to treat people with schizophrenia, the persistence of homelessness, untreated psychosis, and premature death are not simply lapses in our clinical delivery. They are signs of a deeper ethical misalignment. And as a neuroethicist and member of ICONN, I believe we need this new lens that we are going to bring, one that reframes our approach to human persons with schizophrenia from within the interior logic of the human person. And neuroethics, as in its core, is not just merely ethics applied to brain data. It is the systematic and informed reflection dealing with both neuroscientific data and their interpretations. This terms is very important, the interpretation of neuroscience, especially the models we construct of the brain, the mind, and the person. And these models matter. They shape how we diagnose, treat, and legislate. They determine whether our interventions liberate or limit, whether they dignify or dehumanize. And we have to be very clear. Schizophrenia, especially in its most severe forms, impairs not only perception and reasoning, it fractures the very unity of consciousness, disrupting the person's capacity for coherent self-representation and deliberate freedom. And to illustrate this, I propose this biosystemic model of stratified understanding of human consciousness and free will that allow us to locate where and how schizophrenia erodes freedom, and therefore where ethics and policy must respond. And this stratification of consciousness first and free will. In the theoretical field of neuroethics, a stratified model of human consciousness have recently been proposed, conceived as a multidimensional and hierarchical reality, ranging from the most basic physiological levels to complex forms of reflective self-awareness. This approach recognizes the existence of several interrelated functional strata, each with particular neurophysiological and phenomenological characteristics. In this view, human consciousness is not a monolith. It is a dynamic bottom-up structure and system across at least 6 dimensions: interoception, exteroception, integrative perception, awareness, proprioception, and phenomenal self-awareness. So I don't want to stress this point, but we can go deep on all these strata, all the levels: interoceptive consciousness, sensory and perceptual consciousness, basic cognitive awareness, and narrative and reflective self-awareness. This model holds that the different levels are structured hierarchically like the floors of a pyramid, with the higher levels depending functionally on the lower ones. This function at basic levels, such as sensory perception, no? For example, the hallucination, auditory hallucinations, right, can directly disrupt higher level of self-awareness, causing distortion in personal narrative and sense of agency. And this stratified perspective on consciousness aligns with contemporary model of cognitive neuroscience, which describe consciousness as an emergent phenomenon of the dynamic intersection between multiple specialized brain networks, and all the body is involved. And parallel to the stratification of consciousness, a stratified conception of human freedom has also been proposed, understood as a complex and multidimensional phenomenon that is expressed differently at various levels of conscious experience. And this perspective distinguishes several different types of freedom, each associated with a specific stratum of neurocognitive functioning. First, a primary form called interofreedom is identified, which refers to the organism's ability to self-regulate in response to internal physiological states. Although it does not constitute moral freedom, of course, in the strict sense, it does imply a margin of adaptation that allows for flexible responses to needs such as pain, thirst, etc., reflecting a homeostasis that is not completely determined. This level highlights the existence of a basic somatic agency that precedes rational deliberation. There's a second level, sensory motor freedom, corresponding to the ability to initiate, modulate, or inhibit voluntary motor acts based on perception of the environment. Clinical example, for example, the so-called apraxia, illustrate how a person can retain the intention to act without being able to execute coordinated movement, revealing a dissociation between decision and action, right? Higher up is the executive cognitive freedom that manifests itself in deliberative process, action planning, and impulse control, function that depend on the integrity of the frontal lobe and other brain structure. And finally, at the top is reflective freedom or self-freedom, associated with self-awareness and existential self-determination. This level allows the subject, the person, to define themselves based on values, personal goals, and moral decisions, constituting a full expression of personal dignity. So this is a model of understanding this stratification of consciousness and free will. So how schizophrenia disrupt freedom in this sense? So this is how schizophrenia disrupt freedom doesn't destroy the nervous system like, for example, degenerative disorders, right? But yes, there's a disruption of the scrambled layers of architecture of consciousness. Delusion, for example, distort integrative freedom. Hallucinations override external freedom. Anosognosia erases aware freedom. And in its most severe form, self-freedom, the freedom that makes us fully human, is silenced. This is not mere impairment. This is a disintegration of freedom from within. And yet, tragically, our policies too often wait, as we heard, until the patient can choose help, assuming a level of freedom that the Constitution, as the condition, has already dismantled. So here also is the difference between different types of intervention, and the difference between the paternalism versus parens patriae, that I guess is very important. Neuroethics demands that we stop asking the wrong question. We should not be asking, for example, is this person refusing care? But rather, at what level of consciousness and thus freedom is this person operating? If the answer is that self-freedom is compromised, then our ethical responsibility is not inaction but intervention. Recognizing the patient's neurological vulnerability indicates that we are not dealing with intact autonomy, as suggested by Article 5 of the UNESCO Declaration on Bioethics and Human Rights. People who are unable to exercise their autonomy require special measures to protect their rights and interests. This is where we must distinguish between the paternalism, which seeks control, versus parens patriae, which recognizes responsibility for those who cannot exercise full autonomy. People with schizophrenia, especially those with anosognosia, are not merely resistant. They are structurally incapable, at least temporarily, of self-rescuing from a collapsing conscious order. Professionals and the state then have the power and the obligation, I guess, to act with compassion in the best interests of the vulnerable people, even if this means temporarily limiting some freedoms. For example, hospitalizing them against, in the sense is not against, but against their will to save their life. So life is first. Far from being a violation of ethics, such action would be considered an expression of the ethics of protection. A practical example of applying this concept is legislation on involuntary treatment. And so we must speak also clearly in the sense that treatment is not coercion, it is restoration. The stratification of freedom tells us where intervention is not only justified, but ethically imperative. To withhold care until consent reemerges is not abandon the patient to disintegration. That is not ethics. That is abandonment dressed up in autonomy. And so neuroethics applied to schizophrenia patient also require a discussion of the legal responsibility. Our neuroethical call to action that we want also on Tuesday to stress and to reach a consensus in this neuroethical call to action. The intersection between schizophrenia and neuroethics shows us the urgency of integrating the academic theoretical approach with the clinical applied approach. And for this reason, ICONN exists in this sense and represents a contemporary model of neuroethics applied to schizophrenia. Its vision is a world in which people with severe neuropsychiatric disorders receive timely, compassionate, and evidence-based care, rather than being stigmatized or excluded. Its mission focuses on transforming both medical practice and social structure. And so I end with the topic of dignity. Schizophrenia is not just a clinical challenge, it is a mirror held up to our ethical systems. Neuroethics, as I understood it, is the discipline that forces us to look into the mirror, not to despair. We are in the Jubilee of Hope, so we have to have hope. Not to despair, but to reconstruct the moral architecture of care. Let us not longer be complicit in a system that calls neglect autonomy and calls abandonment compassion, and let us instead build neuroethically informed pathways of care, where neuroscience guides us not only towards what is possible, but toward what is just. In the layered ruins of disintegrated consciousness and free will, we must place not blame but bridges back to autonomy, to relationality, to dignity. And because every person with schizophrenia is not a broken machine, they are a stratified, wounded freedom, calling out quietly, incoherently, perhaps even violently, for a chance to be restored. And so this is our task as ICONN. This is our our responsibility, our mission, if you want. And so thank you for being here and to hear our these talks and our vision and mission. Also, if you want to join us, please look at our web page, neuroethicscollege.org. And so, and in the next days, tomorrow, here we are little group of experts that all the day they are figure out and talk about the neuroscience and the application, the pharmacology. And on Monday, Tuesday, we are celebrating here the first ICONN colloquium. So from neuroscience, polity, and neuroethics. And we want to end with a consensus document. So also pray for us, for our work. And now we can open for some interaction with you. And also, I guess there's question of the people that are following us on the web. Thank you so much. I can take the questions. Comments, reflection, interaction. So be free, you are free. Yeah. If you, the microphone, yes. Yeah. Thank you.
My name is Irene. First of all, thank you very much for a very interesting session today. I wanted sort of to address a little bit the first, perhaps rhetorical question of Dr. Stahl. The question was around what can we do? How can we ensure better, more effective communication of this mental disease and of its treatment? And let me say that I'm someone that also worked briefly in mental health. I'm not a doctor. I'm a management consultant. I used to live in the UK and I had some projects and exposure to both private and the NHS in the UK in this space. And I think a lot has to do with stigma and trying to, in terms of policy, to design policies and I guess invest more in education around stigma and try maybe not to fully or completely eliminate stigma around mental health. And I'm not talking just about schizophrenia. I think all mental health, even depression, anxiety, people with these mental illnesses are highly stigmatized, especially in the US. And I suppose that's what leads to a lot of resistance to being diagnosed. So what can we do, not just in the US, but also in other countries to reduce stigma. And connected to this was a question that I had in mind regarding psychosis and schizophrenia. Like, you're right to say that in different cultures, there are different perceptions. So, for example, in India and some places in Latin America, people who hear voices, have visions, are not necessarily considered mentally ill. In certain cultures and populations, they're considered as being in touch with divinity or gifted or different. And I don't know, what is your view on that? Is there something there that we could learn and adopt in our policies or in our thinking about these mental illnesses? And obviously there are various degrees of schizophrenia or psychosis, but I think some people that have these visions and are considered as healers, being integrated in community, manage to lead sort of normal lives or half normal lives. And yeah, so that was my a big question. I don't know if it goes on a tangent, but yes, if you have any views on that, it would be very interesting to know. Thank you.
Thank you. Great points. I do think stigma is an enormous part. And what I have discovered is that people don't understand what psychosis is, and they think if someone is standing on a street corner screaming, that that person is either making a choice or morally deficient or using drugs. They don't understand that there's too much dopamine in that person's mesolimbic system because of a biologically driven disease. And so I do think stigma is a part of it, especially related to psychosis. And that's one of the reasons we're doing what we're doing. And to your point about different cultures viewing psychosis in different ways, I think that's true. And that's one reason why we are the International College of Neuroscience and Neuroethics, because the perspectives that we gain from broadening our narrow lens are extremely beneficial. And I think, for example, in India, we do have some participants from India. There are people who are considered healers. There are other people who are locked away completely from society, and they're just not talked about or seen in society. So I think there's a balance there, but there are cultural elements, I think, especially in countries like Italy, where the culture has a sense of responsibility for its members, and families have a sense of responsibility for each other that we don't have as much in the United States. And I think that ethic, that cultural ethic of responsibility and compassion for your fellow community members drives a lot of the success of the policies. So all very, very good points for us to think about.
Here is a question, I guess, for Dr. Stahl. Carlos said, restructuring of neuronal architecture in adolescence age and schizophrenia. What is known about anatomical and biochemical features?
Well, we know that it happens in everybody, not just schizophrenia. The brain has a way of developing. In fact, the brain actually is very interesting. In utero, it makes about 10 times the amount of neurons that it needs. And then it kills off 90% of them. And I say, why are they doing that? And the thought is maybe that's to make sure you have the right ones. And so you make an abundance of the neurons you need. The brain is so important. Who knows? And then, of course, it has this redundant wiring. Why does it do that? I mean, it seems like a waste. But we do know some things like nerves that fire together wire together. If you don't use it, you lose it. And so there may be something about adolescence in which a patient destined to have schizophrenia is not using the right neurons. And the consequences of that, when the programmed brain decides it's time to eliminate, it eliminates the wrong stuff. It's eliminating things that should have been used. And so there are some statistical way of doing that. For example, if you've got a lot of AMPA receptors, which is a type of glutamate receptor, it means you've been using that circuit. And so lots of AMPA receptors means you're going to preserve that synapse. And if you don't have AMPA receptors, you don't preserve it. And we do think that some of the genetic lesions of schizophrenia converge upon the glutamate system, and that maybe there's inefficient ability to make synapses that's part of the neurodevelopment gone awry. And so if you have a machinery that is defective in making and using synapses, when it comes to neurodevelopment, you may eliminate the wrong ones, and then you end up having schizophrenia. You might ask, why would the human race have schizophrenia in it? It doesn't seem to have any adaptive survival purpose. It doesn't make you live longer. It doesn't necessarily lead to outcomes that are favorable evolutionarily in terms of survival of the fittest. And the answer to that could be a little bit more related to the bipolar, which is close to schizophrenia than it is to schizophrenia itself. What's that? What do I mean by that? It turns out that the genes for creativity and intelligence are very closely linked to the genes for bipolar illness. And not so much in schizophrenia, but again, these illnesses are close. So that maybe the reason that these genes and these abnormalities stay in the human race and don't get eliminated and people don't die off is that there's good stuff that it comes with it too, intelligence and creativity. And the price we have for intelligence and creativity, it might be schizophrenia. That is or bipolar illness. I've done some studies of some famous bipolars, including Nikola Tesla, a European, of course, and Jackson Pollock, a very famous painter, throwing paint around. And these people have a type of creativity that's just not seen. One of my old mentors would answer the question this way: it's not good to be a bipolar or schizophrenic in order to be creative. It's good to be the brother of a bipolar patient, hoping that maybe he got all the bipolar genes and I got all the creative ones. And you do see first-degree relatives of patients with schizophrenia that have creativity outside of it. So these are sort of interesting cultural and philosophical questions. But I don't know that we can actually prevent schizophrenia. It'd be interesting to know whether the programming of the question had to be about, what's the program that actually makes your synapses come and go, and we haven't quite discovered what those are. But I think that that's part of the future, is to try to understand that, and that's the forefront of I think neurobiology right now.
Are there some other comments, question? Well, the question is, Emilia asked, in order to explain schizophrenia, the question is, it excludes any other cause related to life experience of the subject?
So in other words, life experiences are important. We have this thing called the state hospital patient, and they all have the same life experiences. They're born in poverty, They're abused as children. They have neglect. They abuse drugs early. They have brain injuries and brain trauma, and they have the gene for schizophrenia. And so it doesn't look like you inherit schizophrenia or bipolar. What do you inherit? Risk for schizophrenia. Whether that risk becomes manifest depends on your environment. So if you get dealt, I'm living in Las Vegas these days, so if you get dealt a deck of cards in which you get dealt, maybe several of us in this room have the gene for schizophrenia, but we didn't get the other bad cards, which actually were the kinds of life experiences, including what I told you, smoking high potency cannabis. If you avoid some of those things, maybe you kind of tiptoe through the darkness and get away with not having your illness. And in fact, most mental illnesses are probably this. You don't inherit depression either. You don't inherit PTSD. How come half the people going into battle get an acute stress response and only half of those end up having chronic PTSD? There's half of the people don't even get a traumatic response at all. And that's called resilience. Can you make resilience? Can you build that in? Probably. If you have good diet, you've got good genes, you got money, you got education. Education is probably resilience against dementia because you've overwired your brain. And so if you lose 20% of your synapses, maybe it's silent if you got a lot of them. And then maybe it's going to be a memory problem, as soon as you lose one or two, if you don't have that. So that's probably why the intersection of environment and brain work so closely together.
That's another question. So thank you very much for the extremely interesting presentation regarding the stigma and treatment adherence. I'm thinking about the roles of the media and literature as well as cinema, which tend to polarize fear and spread misinformation. Wouldn't creating TV series or film that are more ethically grounded in humanity and science, as you suggest, be the key? Dr. Anna Schmidt-Pereira. Interesting.
Very interesting. And in fact, we have a documentarian coming and joining our group on Monday and Tuesday. A guy named Ken Rosenberg, who's also a psychiatrist at Cornell University in New York, has started making documentary films about people living with schizophrenia. There's a lot of Rosenberg. Yeah, Ken Rosenberg. Yeah. I don't know if you could get this here, but on HBO, there's a documentary film series he created called Bedlam. And he's going to be part of our group on Monday. So I think that's a very good point to demystify. We actually were passing around an article that came through CNN, which is a US media outlet that actually took a objective scientific look at schizophrenia. And it was kind of shocking to see something that was not sensationalized or ideologically polarized in the mainstream media. So maybe we're making progress in that direction.
Last question here. Oh, yeah, please. Yeah. Last two questions.
Maybe this is something in the middle between a question and a comment. So when you spoke so effectively about the cycle of criminalization, there is another thing to be mentioned in this context, is death penalty. Death penalty very often is at the end of the cycle of criminalization. I come from the incredible experience of the number of executions made in Florida just in the months of this new year. 11, something top record in the history of the United States. One of them was a close friend of a friend of mine. They have been pen friend for 30 years. Curtis Wyndham, a man who surely suffered of trauma, child abuse, was considered not be able to stand the trial. After 30 years in death row, has been executed on August 23rd. Many people here in Italy, 10,000 people wrote to the governor, Ron DeSantis, but he didn't do anything. Instead, I think he's happy to, I don't want to enter into politics, obviously it has something to do with the present American administration. But don't you think this is another difference between not only Italy, but also Europe and the United States? It's a stigma. The United States, in several states, luckily not California, still keep the death penalty that is considered brutal and medieval in European context. Thank you.
You take that one. Yeah, you have to comment.
Well, of course, I agree. I against the penalty, of course, but yes, yeah. The problem is that I guess I don't know the statistic, but maybe some of them they're like, for example, there's the famous case of the Milwaukee cannibal, right? Do you okay? There,
Jeffrey
he
Dahmer?
he was crazy. Right? He was obviously crazy, right? And maybe something was thinking about some neurological problem, etc. There's another famous case of people shotting, and after that they was shot and they found a brain tumor, etc. So there's complex situation, of course, and I guess yes, a different would be like of considering like the way in which we consider um, the rehabilitation program, or the way that jail or prison has a purpose to rehabilitate people in order to also be aware of their crime, etc., and be better, right? And so I guess this is the mission of the system, right? Not like eliminate, but it's very easy to eliminate in the sense, or easy in the sense. It's harder to work and restructure as we want also with our project. We want to restructure things that are not functioning, and is more harder and is very difficult because it's a progress of change culture in this sense, change mentality, right? Change the way in which we see the problem, right? A person that see a guy screaming on the street, etc. There's people that think, oh, he's insane, he's a ill person. And there's another people that say, oh, call the police because I interpret this situation as a threat for me, right? So this has two kind of see the same picture of the reality, right? So we are working in order that we see people, right? Illness people that we want to restructure in this sense, right? Thank you.
I just wanted to make a point, and I don't know if you both know this, but when we were at Twin Towers Jail in Los Angeles, we saw an incredible mental health program that was run by inmates, where non-mentally ill inmates were caring for mentally ill inmates, and it was an incredible program. And the founder of that program is a death row inmate, and he wrote a chapter for our book that's coming out. So just speaking to redemption.
Oh, the last one comes from Latin America. So in Latin America, there is a serious problem with drug addiction, not only in Latin America, unfortunately, but that leads to schizoid disorders. It's hard to tell apart people with a pre-existing condition from those who develop a substance use disorder. Can we identify the difference? In education, this is important because as teachers, we can't just ask every student whether they use drugs or not.
Well, if you have a patient who takes a stimulant like amphetamine, methamphetamine, and cocaine, and you have a patient with schizophrenia, and they're in the bed next to each other in the emergency room, you can't tell one from the other. They look identical. It has the same psychotic symptoms. Interestingly enough, those drugs release dopamine in the same area of the brain that a schizophrenic has too much dopamine by a non-drug mechanism. And to make it even more difficult, many patients with schizophrenia abuse stimulants. So that's taking a fire and putting gasoline on it. So I think that it's sometimes imponderable and impossible to separate them. And you know, the issue about patients committing crimes is compounded when a patient with this schizophrenia does abuse drugs, and they're the ones that are the more violent ones, and they're the ones that get into more legal trouble. So I think, you know, substance abuse is an illness which can look very much like schizophrenia.
So we end here. And so thank you very much for Dr. Stahl, Dr. von Burtur, and you're in the audience, and also the people connected through Zoom. And so for the people in presence, we join a brief, like very a buffet. And so for the online audience, please join your dinner. And so see you next month on October. And thank you very much. And thank you. Grazie a tutti per essere stati con noi, coloro che si sono collegati e coloro che sono qui in presenza. E noi ci rivedremo, continueremo il prossimo mese le nostre attività. E sarà un anno molto ricco, perché da qui iniziamo il nostro programma di ricerca, che è già iniziato realmente il 3 luglio, anzi è già iniziato ancora prima, però il 3 luglio abbiamo avuto quel webinar con la professoressa Matilde Leonardi e il professor Alberto Beretta, che un po' sono i coordinatori anche delle due ali, potremmo dire così, neuroscientifica e poi le due parti scientifiche del nostro programma sul tema Brain Health and Longevity, la salute cerebrale e mentale e la longevità, che culminerà quasi cronologicamente con il Second Vatican Longevity Summit il 25-26 maggio del prossimo anno in Vaticano. Sono già confermati 2 premi Nobel. Ritornerà il professor Ramakrishnan, Nobel Prize for Chemistry, e il professor Thomas Sudoff, che è premio Nobel per le neuroscienze, quindi avremo premio Nobel per le neuroscienze, e sta per confermare una donna premio Nobel, quindi non dico il nome, però vogliamo appunto un'amica, collega nella Pontificia Accademia per la Vita, ve lo dico. Dovrebbe confermare anche la professoressa Caricò, Nobel Prize 2023, per i vaccini mRNA messaggero, che insieme è membro della Pontificia Accademia per la Vita. E questi progetti sono sotto anche la guida e il patrocinio, il Vatican Longevity Summit è patrocinato dalla Pontificia Accademia per la Vita nel primo evento di marzo di quest'anno. Abbiamo anche avuto il messaggio del Santo Padre Francesco proprio il giorno dopo le sue dimissioni dall'ospedale Gemelli, e siamo molto contenti perché diciamo, insieme agli altri progetti sull'intelligenza artificiale eccetera, il Vaticano vuole approfondire il tema dell'etica e i modelli etici di longevità, un tema enorme, un tema che ha tantissime implicazioni sociali, e che continua a essere un'occasione per riflettere anche sul tipo di società che vogliamo, sul tipo di persone che vogliamo essere e diventare. Grazie a tutti e buona serata.